Hello everyone, welcome to our first fracture conference. Today we're going to discuss a fibula fracture. I know that some of you who are watching might think that this is a relatively simple fracture for us to discuss, and it is, and I think it's perfect for our first episode. It's going to allow me to sort of get my feet wet as we try to figure things out here, but it also will give us an interesting case that we will have lots of different things that we can talk about. As we go along, if you have questions, concerns, comments, criticisms, please feel free to leave them in the comment section below. At the end, I'm going to ask some poll questions. We'll put those on my Twitter, and I'm interested to hear how all of you will respond to some of the different questions about the different controversies that are even in the treatment of seen even in the treatment of fibula fractures. I'll put my Twitter handle below. If you don't follow, my Twitter is RKH_MD, and we'll have lots of different interactive things as we go along here on Twitter. One of the most interesting or one of the most fun parts about Fracture Conference is the interaction, so I encourage that. I have 3 other trauma partners where I work, and every morning we have Fracture Conference with our residents, and we're always arguing back and forth trying to figure out how or to decide what is the best way to fix a particular fracture. Even though there are multiple ways to fix any individual fracture, we'll always try to stick to the principles. If we stray from the road, I'll explain my reasoning, but you won't find that happening too very frequently. If you haven't already, please make sure you subscribe. Make sure you hit the notification button, and every time we post a video, you'll get a notification of a new video. We'll plan to do this once a week every Friday, and I hope that it really turns into something that we can all learn from. Let's get started. We'll cover some anatomy before we go on to the case. I'll link a picture below so that you can follow along. The ankle is made up of 3 bones and 2 joints. The bones are the tibia, the fibula, and the talus. The joints are the tibio-talar joint. That's the major joint that we walk up and down on and allows us to move our ankle up and down. And then we have the distal tibio-fibular joint, or some people call it the syndesmosis. This is the joint between the tibia and the fibula, and a lot of times if you're not familiar with this joint, you may hear in athletics people talk about high ankle sprains. This is a sprain of that particular joint. There are multiple ligaments on each side of the joint that create stability and allow us to walk or run on even or uneven surfaces with ease. Remember that bones are covered with muscle and skin. These must always be taken into account when managing fractured bones. Between the skin and bones are blood vessels and nerves. If we want to operate on bones, we often have to take approaches into account that will avoid damaging these structures. We'll bring this up for many, but perhaps not all of the cases that we discuss. It is something nonetheless that we should keep in mind at all times. So let's start with our case for today. Our case is a 42-year-old gentleman who suffered a twisting injury to his ankle. This injury was actually about 2 weeks prior to his arrival to see us in the office. The patient had been seen in the emergency department and was placed into a boot and instructed to follow up. Here are his x-rays from when he comes to see us in the office. We have the standard 3 views of the ankle, and we also ordered a gravity stress view to help us understand the stability of his ankle joint. So if you aren't familiar with reading x-rays, I'll put some arrows on the pictures that you see on the screen there to point out where the fracture is. But this patient has a fractured fibula. The fracture starts on the lateral aspect of the fibula and sort of travels down towards the joint. That's on the frontal view. If you look at the side or lateral view, you'll see that the fracture travels from posterior superior to anterior inferior. This is a relatively standard fracture pattern that we see in fibulas, and I'll explain a little bit more in a second when we talk about our classification system. You can also see on our radiographs this gravity stress view. So our x-ray tech suspended the patient's leg or ankle on a bolster, and then took the x-ray in what we call the mortise view, which I'll show you the comparison of the of the x-ray without the gravity stress and with, and you'll notice that on the inside part of that ankle there you see some opening. So we call this medial clear space widening, and this is an indication that this patient has an unstable ankle fracture. So I mentioned classification scheme. If you aren't familiar, almost all fractures have some sort of classification scheme. There are a taxonomy that allows us to identify different fracture patterns, as most fractures do tend to occur in predictable patterns. And we can take those fractures and predict what the outcomes will be most of the time based on our classification, or perhaps the classification helps us understand how severe the injury was. A lot of classifications will help us to guide how we treat particular fractures or injuries. There are two classification schemes that we frequently see with fibula fractures and ankle fractures in general. One of them is the Weber classification. That's specific to fibula fractures and talks about the location of the fibula. So we have the ankle joint, or the tibio-talar joint that I was talking about earlier, and this classification scheme is based on where the fracture exits the fibula in comparison to the tibio-talar joint. We have A, B, and C. A fractures exit below the tibio-talar joint. These tend to be relatively stable fractures and are almost never necessary to be treated with surgery. B fractures exit at the level of the tibio-talar joint, and these fractures are a lot more unstable than the A-type fractures are. The same goes for C-type fractures. C-type fractures C-type fractures often have injuries of that distal tibiofibular joint, and so these are relatively unstable fractures and can often require a surgery to fix. In addition to the Weber classification, we also have the Log-Hansen classification. The Log-Hansen classification is a little bit more complex and has a lot to do with other parts of the ankle, and really takes into account all of the bones and joints in the ankle. That particular classification scheme depends on the position of the foot at the time of the injury. The foot can either be what we call supinated or pronated. So that's the first part. And then the second part has to do with the deforming force that happens to the ankle at the time of the injury. So we can have abduction, abduction, adduction, adduction, or external rotation. The most common injury pattern, and the injury pattern that we see in our patient today, is the supination external rotation injury. This is a fibula fracture that goes from posterior superior to anterior inferior. I'll draw that out and put a picture up on the screen for you to help you see and visualize that. This classification typically describes injury around the ankle in as we travel around from one side to one portion of the joint and ligaments to the other side. So this particular injury again is a Weber B, or a supination external rotation injury. These are often injuries that require this gravity stress view, because depending on the severity of the injury, depending on how much of the ankle was injured, we may or may not require a surgery to fix them. Even relatively unstable fractures, so fractures like this one that we see on the on our particular patient that open on a stress view, may not require surgery. Not every patient is a good candidate for surgery. Patients that aren't good candidates for surgery can be treated in a cast, and we may keep them from weight bearing on the ankle until the bones can heal. Whereas somebody who has a stable injury pattern or who doesn't have increased opening on their gravity stress view, perhaps we wouldn't consider or discuss surgical treatment of their fracture, and we let them weight bear as tolerated in a protective brace. Our patient's relatively healthy. They have asthma and are a smoker, but no other significant medical injuries. They work in retail food sales, so they're on their feet a lot and depend on being able to ambulate to do their job. So we discussed the treatment options with this patient, and they elected to undergo a surgical repair of their fracture. So if I was planning for surgery in this particular patient, let's talk about my OR preparation plan. How would I set this patient up for surgery? So first of all, they would need to be on a radiolucent table. That's a table that we can take x-rays through so that we can see the bones and make sure that we're putting our fixation in the right place and that we've reduced our ankle fracture and our ankle joint appropriately. We use a bump on the lateral aspect of their hip so that we can roll that outside or lateral part of their ankle inward so that we can more easily access the bone. If you think about how most people were to lay, if they were just flat, their legs and ankles tend to roll outwards, or what we call externally rotate at their hips. So we need to put that bump in there in order to get better access to the fibula. I like to use an ankle positioner, which is just sort of a foam ramp that puts the ankle above the other leg. That makes it easier to take x-rays and props up the leg a little bit for easier fixation. You can or do not necessarily have to use a tourniquet. Tourniquets are often used in lower extremity surgery. I use them sometimes and don't use them other times. Depends on a lot of different factors like the patient and the severity of their injury. If they have any other medical comorbidities like bad vascular disease or poor blood flow to their leg, I may not use a tourniquet. I tend to use a tourniquet more frequently when I'm operating with residents because I think it's easier for visualization. It's easier for me to see and them to see. And we're spending more time thinking about fixing the fracture than we are trying to make sure we're keeping good hemostasis or not having a lot of blood in our field. So we need an operating room and a table to operate on. We need a table that can x-ray through. We need to make sure we have the patient positioned in an appropriate way so that we can x-ray them and operate on them in a comfortable and ergonomic fashion. In terms of our preoperative plan for this patient, our plan will be to make an incision on the lateral aspect of the ankle, the outside part of the ankle, to dissect down through the skin and subcutaneous tissues there and protect the superficial peroneal nerve, which is a nerve that sits right in front of our fibula and supplies sensation onto our foot. This nerve can get into our way sometimes when we're dissecting down or when we're operating on that fibula there. So we have to be really careful about the superficial peroneal nerve. Below that, there really isn't much other than the bone itself. So once we get to the bone, we identify the fracture. We open it up and we take any soft tissue that may be in between the fracture out of the way. If a patient has a relatively new fracture, we often don't have problems with this, but if the fracture has been given a few days to start healing, then there's some soft tissue that gets in the middle of the fracture and we have to clean it out. We also wash out or irrigate the fracture site and the ankle joint itself to make sure that there's no debris that will get in between the bones and prevent healing. Once we've accessed the bone and got good clean site, then we use a clamp to squeeze the bone together and reduce it or put the two edges together. We call this an anatomic fixation or an anatomic reduction if the two bones are touching exactly the way they were the day that we were born. Once we have a reduced fracture, we need to hold it there. To do that, if there are simple fracture patterns like this simple oblique fracture pattern, we hold it together with a screw. This is called a lag screw. The way we create a lag screw is by over drilling one side of the bone. So if we have a 2.7 millimeter screw, we drill 2.7 millimeters on the side, on the side that's closest to where the bone will, or to where the screw head will sit. And then we drill what the inner diameter of the screw is on the opposite side. So that's 2.0 millimeters. And then what this does is it allows the screw threads on the most distal, the furthest away from the screw head, to capture the bone and to squeeze the two pieces of bone together. Once we have the fracture reduced and held that way, we also put a plate and screws over top of that particular lag screw to do what we call neutralize the bone. So we're protecting that lag screw, which is holding the two fracture fragments together, with this plate and screws on the opposite side of the bone, to allow the bones to have good stable fixation and to heal. One of the things that we should talk about, and that we'll talk about more as we go, is what are the different ways that bones can heal. When we use this particular method, where we have what we call anatomic reduction, or rigid fixation with this screw tightly squeezing the two pieces of bone together, we get something called primary bone healing. So if you think about what happens when you remodel your kitchen, you tear the kitchen apart, take all of the old appliances and countertops and cabinets and things out and bring new in. When we have primary bone healing, we have special bone cells called osteoclasts, which actually burrow their way through the bone and tear it down, so that the cells that create bone, called osteoblasts, can come along and lay down new bone. So we've taken our old bad fractured bone, chewed it up and eaten it away, and put new bone in its place that's just as strong as when we started. I want to talk a little bit about lag screw choices. So I like to use a 2.7 millimeter lag screw. Your two basic options are 2.7 millimeters or 3.5 millimeters. I like the 2.7 millimeter size because it's a little bit smaller. The head of the screw is a little bit less prominent, and it really fits a little bit more nicely, in my opinion, into what's a relatively small bone as opposed to the 3.5 millimeter size. There's nothing wrong with the 3.5 millimeter size, and a lot of people use that size, but I like the 2.7 millimeter screw a little bit better. In terms of the plate that we're going to plan to use, or that we're going to use to create our neutralization, we're going to use something called a 1/3 tubular plate, which is a very simple plate that sets on the side of the bone. Stainless steel plate. We use stainless steel screws. You can use a couple of different kinds of screws to affix the plate to the bone. We have cortical screws, which are just standard screws and look a lot like screws that you might use for any other application that you're screwing two things together. We have something called cancella screws, and if you look at the threads on a cortical screw versus a cortical screw versus a cancella screw, you'll see the threads on the cancella screw are a little bit wider. That's because you're actually using a cancella screw to dig into the bone that's inside the bone to provide your fixation. When you're using a cortical screw, the outside portion of the bones are called cortices or cortexes, and so when you use a cortical screw, the screw threads are digging into the cortex, and that's how we get our stability. You can also use something called locking screws. Locking screws have threads in the head, and then there are threads in the plate that these screws will lock into. So we have lots of different screw options. We'll go over many of them as we go along through different cases. In this particular case and patient, we used cortical screws on the most superior or top portion of the plate. That's a good portion of bone where there's good cortical, where there's good cortices that you can screw into. There's also not a joint on the other side of these screws on top, so you don't have to worry about screws impinging on a joint. down towards the bottom of the fibula or the distal end of the fibula, you do have to worry about this. So we tend to use either cancella screws or locking screws, and most of the time, especially in young healthy individuals, we'll just use cancella screws, and they do perfect for this particular purpose. So after we have our fracture all fixed up and held in place, then we use an x-ray machine called fluoroscopy to look at the fracture, to look at our implants that we put in there, and to look at the ankle joint and make sure that everything is well aligned and where it should be. And in this particular patient, here are our x-rays or our fluoroscopic images that show our fracture reduction. So you see we have the one lag screw and then the plate and the additional screws. And you can see that we have a nice reduction of our fracture and that our implants are held up against the bone like they're supposed to be. But more importantly, that our ankle mortise, so we don't have that instability, we don't have that widening of the ankle or the ankle joint or ankle mortise that we had before doing surgery. So after we've done the patient's surgery, what do? We close up the fracture, or excuse me, close up the skin with sutures, and then we put a splint on the patient and we send them home from the hospital. The splint is typically kept on for about 2 weeks. We bring them back in the office and see them, take a look at their incision, take out their sutures as long as they're ready to come out. And then we put them into something called a walking boot. I'm sure you've seen a lot of people in walking boots. We don't let people start walking right away though. The walking boot's more of a convenience thing. People are allowed to shower, don't necessarily have to sleep in it. Certainly more easier to live in this boot than it is to live in a splint that you can't get wet. Weight bearing times can vary from immediately to within 2 weeks after the surgery, and some people wait for at least 6 weeks after the surgery. If you have a more complicated ankle fracture, sometimes it can be up to 3 months before you can put any weight on on that particular fracture. For this patient, we elected to keep him non-weight bearing for 6 weeks. So we'll keep him without putting weight on this ankle for a month and a half. Once we get to that month and a half mark, we'll let him start putting weight on it, working with physical therapy. When we bring the patient back in the office 2 weeks after their injury, take that splint off, let him in a boot. We do encourage them to start working on motion of the ankle. We don't want the ankle to get too stiff. That can be even a bigger problem than the fracture was to start with. So after that 2-week visit, we follow the patient until their fracture is healed. For a lot of patients, this is really only about 3 months. After that 3-month visit, a lot of patients are doing fantastic. And we release them and see them on an as-needed basis. Physical therapy is something that I sort of do with patients on an individualized basis. A lot of patients, especially younger and active, healthier patients, don't require physical therapy. They get along pretty well. I do put patients into a lace-up ankle brace when they're ready to come out of their boot, which is usually a couple weeks after we start weight bearing. Have them wear the lace-up ankle brace for 2 or 3 weeks and then transition to tennis shoes before they're comfortable wearing whatever shoes they like and prefer. Long-term outcomes for ankle fractures, as long as they're well fixed, are very good. The risk of arthritis and minimal fractures is pretty low as long as we have a well-fixed fracture and we've got our ankle well reduced and there is no more instability in the ankle. So that's our case. Show you some post-op x-rays for this particular patient. He went on to have a well-healed fracture and is doing very well and did not have any complications or issues after this particular injury. Every week I'm going to try to provide a journal article that I like that talks about our fracture for the week. This week I'm going to link below an article that comes from the JAOS, the Journal of the American Academy of Orthopedic Surgeons, also called the Yellow Journal. This is a relatively simple and good description of ankle fractures and talks about anatomy, diagnosis, and treatment, and it's one of my favorite articles about ankle fractures. So something for those of you who are interested, who have access to read. Talk a little bit about what some of our poll questions are for this week. I'm going to put a poll question up about how Those of you who fix ankle fractures like to position the patients. Do you prefer supine or lateral for these relatively simple ankle fractures? Have a poll about whether or not you like to use a tourniquet. Put a poll up for whether or not you put patient in a splint after the surgery, and what your weight bearing status is that you choose for patients with this type of fracture. So I look forward to seeing those responses and any comments that you all might have below. Again, just a reminder, the polls will be on my Twitter account, my handle below, also at RKH_MD. And then make sure you subscribe and hit the notification button so that you know when we have our fracture conference next week. All right, everyone. Have a good week, and we'll see you next time.